Welcome to this NIMART training video on sputum induction for TB diagnosis in children. The purpose of this instructional video is to facilitate community-based diagnosis of uncomplicated pulmonary TB. This video is a guide on performing sputum induction in children to collect good quality sputum specimens while adhering to infection prevention and control requirements. It is important to note that sputum induction should be performed when indicated by Western Cape policies and according to your scope of practice. Sputum induction is an effective way to collect sputum samples from the lower airways in children who are not able to cough up sputum without assistance. Sputum induction for children involves three main steps. The first is pre-treatment with salbutamol, a bronchodilator to prevent bronchospasm and wheezing, which may be caused by the procedure. This is followed by nebulization with hypertonic saline, which is used to loosen the secretions from the lower airways. And then the collection of sputum, either by suctioning the nasopharynx in younger children or by coughing up sputum in older children, also known as expectoration. Let's start by looking at the safety aspects and precautions for this procedure. Sputum induction is a low-risk procedure and is safe even in young infants, but nebulization with hypertonic saline may cause severe coughing, wheezing, or bronchospasm. So to minimize the risks, it should only be performed after pre-treatment with salbutamol. Children should not eat or drink for 2 to 3 hours before the procedure. And for children with asthma or impaired lung function, the procedure should be performed under supervision with oxygen saturation and pulse rate monitoring throughout. It is important to ensure that the child is well and that sputum induction at a primary healthcare facility is appropriate. Do not perform sputum induction in an acutely unwell child. This includes a child with any of the following: any signs of respiratory distress like difficulty breathing, chest indrawing, nasal flaring, grunting, unable to feed, struggling to speak, blue lips and tongue, or an oxygen saturation of less than 93%, or a child with abdominal distension or persistent vomiting, a child with headache, neck stiffness, seizures, focal neurology, or decreased level of consciousness, severe back pain, or an abnormal curve of the spine. A child with any of these signs or symptoms should rather be managed urgently according to IMCI and referred to the appropriate level of care. The procedure causes the child to cough, so to avoid complications, do not perform sputum induction in a child for whom severe coughing may be harmful. This includes a child with any of the following contraindications: hemoptysis or coughing up blood, uncontrolled lung disease, unstable heart or lung problem like arrhythmias, aneurysms, pulmonary emboli or pneumothorax, recent major surgery to the heart, lungs or eyes, recent chest trauma, and as I mentioned earlier, a child with respiratory distress or difficulty breathing, or a child who is unable to protect their own airway, for example if they have a decreased level of consciousness. If there are any of these contraindications, you should discuss or refer them for further TB investigations at the appropriate facility. When performing suctioning in younger children, there is a risk of nosebleeds caused by damage to the blood vessels in the nose. For this reason, do not perform suctioning in a child with a bleeding tendency. Sputum induction in the communities should be avoided in children who are acutely unwell or are at risk of severe complications. If you find the child has any of the signs, symptoms, or problems we have listed, rather discuss or refer them for further investigation at an appropriate facility. It is important to use a designated area that is in keeping with infection control standards and policies for aerosol generating procedures. Use a well-ventilated isolation room, keep the door closed but the windows open, and a fan can be used to improve ventilation. Have a sign on the door indicating that nobody may enter when the procedure is in progress, and ideally leave the room empty for at least 15 minutes between procedures. Adopt general precautions to decrease your risk of occupational infection. Wear appropriate PPE, like an N95 respirator throughout, gloves and aprons when handling secretions, and eye protection ideally should be worn throughout the procedure. Dispose of sharps and medical waste correctly. For more information on how to protect yourself in the workplace, see this page in PAC for more guidance on how to prevent and manage occupational exposure to TB and respiratory viruses. Now let's look at the equipment to be collected and used for the procedure. Collect all the equipment needed for infection prevention and control during the procedure, including appropriate PPE for aerosol generating procedures as guided by policies, along with masks and aprons for the caregiver too. Collect alcohol-based sanitizer and red-lined medical waste bins and sharps bins. Ensure you have sputum specimen containers, laboratory forms and specimen bags, and stationery and a marker. For pre-treatment with salbutamol, collect the salbutamol meter dose inhaler with a spacer and the appropriate sized pediatric mask or baby mask. The spacer may need to be prepared according to the manufacturer instructions before use. The spacer should either be primed with 2 sprays of salbutamol before use or washed with detergent and left to dry without rinsing. Be sure to check the instructions that come with the spacer available at your facility. For nebulization, collect 5% hypertonic saline solution. If 5% hypertonic saline is not available, 3% hypertonic saline can be used, and this is usually stored in the fridge. Collect 5 or 10 ml syringes and a needle to draw up the solution, a nebulizer with a nebulizer mask and tubing, and ensure that the appropriate sized mask is available. For suctioning, collect a sterile mucus extractor with a feeding tube or a suction catheter, which is usually 5 to 8 French, and a wall or portable suction machine with tubing. Collect cotton wool, gauze, sterile water, paper towels and a kidney dish for use during the procedure. Now let's look at how to perform sputum induction. Wash your hands and put on the appropriate PPE correctly. Start by introducing yourself and explaining your role to the caregiver. Assess if it is appropriate to perform the procedure at your facility and ensure that the child has had nothing to eat for 2 to 3 hours before. Explain the procedure and the risks to the caregiver and the child if age appropriate. Obtain and document verbal consent in the child's notes and advise them to return in 2 days for the results. For younger children, explain the steps of the procedure to the caregiver or assistant, as you will need their help to hold and keep the child calm during the procedure. Explain that you will first pre-treat and give the child a medicine with the spacer and the mask, which the child must breathe in. Then you will nebulize them with a salty mist that comes from the mask, which will loosen secretions from the lungs and make them cough. Any saliva should be discarded into a separate container like a kidney dish, or they can use a paper towel to wipe away saliva if needed. When the child starts coughing or when the nebulizer is done, they must call for assistance so that you can collect sputum with suction. Explain that there may be bleeding caused by damage to the small vessels in the nose. It is important to explain that the procedure may be uncomfortable but not painful for the child. Next, prepare the salbutamol MDI and spacer by shaking the meter dose inhaler well and inserting the inhaler into the spacer. If needed, prime the spacer according to the manufacturer instructions. Nebulizer. Using a needle and syringe, draw up 5 ml 5% hypertonic saline and add it into the nebulizer cup. If you do not have 5%, 3% hypertonic saline can be used. Ensure the parts of the nebulizer cup are properly assembled and closed, and connect the tubing from the cup to the nebulizer with the oxygen supply. Hang this aside until you are ready, and discard the needle in the sharp spin. Use the same syringe to draw up 1 ml of sterile water to moisten the child's nostrils, and set this aside until you are ready to suction. Check that the suction is working by closing the end of the suction tube with your thumb, and watch the pressure gauge rise. Adjust the suction pressure to between 80 to 120 millimeters of mercury for children, making sure not to exceed a maximum of 100 millimeters of mercury for neonates. Then ensure the mucus extractor lid is properly closed to prevent spills. If the feeding tube is not attached, attach it to the second port on the mucus extractor lid. Attach the mucus extractor to the suction machine tubing, ensuring they fit well into each other. Be sure to keep the suction tube catheter clean by placing it in the original packaging. Now let's start the procedure. Give the caregiver an apron and mask to put on for the procedure, and sit the child on the caregiver's lap. Using the syringe you prepared, insert 2 drops of sterile water into each nostril to moisten the nasal mucosa. Clean the child's nose with cotton and sterile water if needed. Attach the pediatric or baby mask to the spacer, and then, holding the empty eye in one hand, place the mask over the child's nose and mouth and hold it in place to create a seal on the face. Press the empty eye pump once to release 1 puff into the spacer. Still holding the spacer in place, count for 10 seconds as the child breathes in and out. Then press the pump again to release a second puff of salbutamol, and again count to 10 seconds as the child breathes. For the older child, ask the child to breathe out, and then form a seal with the lips around the mouthpiece of the spacer. Then press the pump once to release 1 puff of salbutamol into the spacer, and ask the child to take 4 deep breaths, keeping the spacer in the mouth, or to breathe in and out while you count for 10 seconds. Repeat this to give the second puff of salbutamol, again waiting as the child breathes. After giving salbutamol, wait 5 minutes before starting the nebulization. While waiting for the 5 minutes to pass, with the end of the suction catheter, measure the length to be inserted in order to suction the nasopharynx. Measure from the tip of the child's nose to the tragus of the ear. Take note of this length using the markings on the tube, or use a marker to mark this length on the tube. This will be the length of the suction catheter tube you should insert during the procedure. Again, be sure to put the suction catheter aside and keep it clean. Place the prepared nebulizer mask on the child's face, covering the nose and the mouth, and secure it with an elastic around the head, or ask the caregiver to hold it in place. Start the nebulizer at 5 to 7 liters per minute and check for misting from the mask and in the tube. The nebulizer should run for 10 to 15 minutes, or until the solution is used up or the child starts to cough. If the child develops any signs of breathing difficulty or wheezing, stop the nebulization immediately to assess and manage the child urgently. For the older child, place the nebulizer mask with 5 ml of 5% hypertonic saline on the child's face, covering the nose and mouth, and secure it with an elastic around their head. Start the nebulizer and check for misting from the mask and in the tube, and instruct the child to breathe in and out through the mouth. Nebulize for 10 to 15 minutes until the solution is used up or the child starts to cough. Give them a specimen container to cough into, and if the child develops any signs of difficulty breathing or wheezing, again, stop the nebulization to assess and manage urgently. Once nebulization is complete, or if the child starts coughing, you can perform suctioning. If the child does not cough after nebulization, chest percussion can be done over the front and back of the chest using cupped hands. To perform suctioning, with the suction off, Gently pass the suction catheter through the nostril and advance it to the measured length. Once the measured length is inserted, apply suction and suction for only 5 to 10 seconds. You can move the catheter around a little or turn it once it's in place to facilitate a cough reflex. Then stop the suction and remove the catheter. It is important to switch the suction off when inserting and removing the catheter. This also prevents collection of nasal secretions, which may reduce the quality of the specimen. After suctioning the first side, allow for a short rest before suctioning the other nostril, using the same steps. Stop the procedure once an adequate volume of at least 2 ml is collected. To collect secretions that may be stuck on the inside of the suction catheter, flush the catheter with 2 to 5 ml of sterile saline. If the sample is inadequate or less than 1 ml, nebulization, chest percussion, and suctioning can be repeated once more, using the same steps described before. Remember, do not force the catheter into the nostril if obstruction is felt. Rather try the other nostril, and do not apply suction for longer than 10 seconds at a time. Seal the mucus specimen in the mucus chamber by removing the extractor lid of the mucus extractor. This is the lid where the tubes attach, and then replace it with the lid found at the bottom of the mucus extractor. It may need to be twisted off the bottom. Ensure that the lid is tightly sealed to prevent leaking or contamination, and dispose of the extractor lid in a red-lined medical waste bin. In the older child, suctioning does not need to be performed. Rather, they are encouraged to cough up sputum using these steps. If they cough during nebulization, they must remove the mask and cough sputum into the specimen container. Remind them to collect sputum, not saliva, and that they can use the paper towel to wipe away saliva or spit saliva into a separate dish if needed. If they do not cough before, or if more sputum is required, chest percussion can be done over the front and back of the chest using cupped hands. After nebulization and chest percussion, if they did not cough before, or if more sputum is required, the child can be encouraged to breathe in and out deeply 2 times, and on the 3rd breath, the child is to give a deep, strong cough to bring up sputum. If the sample is inadequate or less than 1 ml, nebulization, chest percussion, and coughing can be repeated. After coughing into the container and collecting an adequate specimen, replace the lid and screw on tightly to prevent leaking. The child and caregiver are to wash their hands after sputum collection and clean the child's face with water and cotton wool gauze. Be sure to safely dispose of all single-use equipment used for the child into the red-lined medical waste bin, including the aprons, disposable spacer and mask, nebulizer, mask and tubing, suction lid of the mucus extractor, used cotton wool, gauze, paper towel, syringes. And remember that sharps should be disposed of in the sharps bin. Disinfect and sterilize equipment that may be reused. Remove and discard PPE appropriately. Sanitize or wash hands with soap and water before and after the procedure. And all surfaces and the nebulizer should be cleaned before and after each procedure. After the procedure, once the child settles, remind the caregiver to return for results in 2 days. Observe the child further if they are not settling or if they have any difficulty breathing after the procedure, and assess and manage them urgently. We will discuss this further later in the guide. Now let's look at how to prepare the sample for transport to the laboratory. Check that the specimen is adequate and is at least 1 to 2 milliliters in volume. Ensure that the lid is tightly sealed and wipe the outside of the container with a 70% alcohol solution with paper towel to prevent contamination. If the induced sputum specimen is inadequate, discuss and then refer the child for further investigation. Label the adequate specimen jars with the child's details and place the barcode label on the specimen jar so that it is clearly visible and can be scanned easily in the laboratory. Complete the standard National Health Laboratory Services TB investigation form, clearly indicating which test you want, for example the gene expert, and complete the TB information section for the child, marking off their HIV status and their previous TB results, and that the specimen is an induced sputum. Seal the container in the individual sleeve of the plastic specimen bag provided, and the form goes into a separate sleeve of the specimen bag. Send the specimen to the laboratory as soon as possible. If the room temperature is warmer than 25 degrees Celsius or transport is delayed, store in the refrigerator at 4 to 8 degrees Celsius or in the designated cooler box. Wash your hands after handling specimens. Complete the TB identification and follow-up register. Ensure the client information is captured in the tier.net by data entry clock if the service is available, and make notes of the procedure in the client's record. Before ending off, let's look at how to manage difficulty breathing that may develop during or after the procedure. If during the procedure the child develops difficulty breathing, stop the procedure to assess and manage the child according to IMCI. Give urgent attention to the child if the child develops difficulty breathing and any of nasal flaring, grunting, blue lips or tongue, lower chest indrawing, oxygen saturation of less than 92%, the child is restless or irritable or has a wheeze. Give oxygen at 2 liters per minute via nasal prongs and manage them according to IMCI, referring them urgently. If the child has a wheeze, again manage them according to IMCI. Assess the severity, and if severe, refer and urgently manage them. Give salbutamol according to IMCI and monitor regularly until resolved or referred. In conclusion, it is our role to ensure sputum induction is performed safely and correctly in the community. Sputum induction should be avoided in children who are acutely unwell or who are at risk of severe complications or harm. Samples should be checked and prepared correctly for transport to the laboratory. And completing registers and record keeping is an important part of linking children to care. Thank you for playing an important role in the early diagnosis of TB.